Hello. Can you guys hear me? Yes, excellent. Thank you. Oh yeah, the clicker, I'll need that. Firm press is what he said. Okay, how many people here are doing PRP? Good, all right, and then BMAC? Okay, great, good, that's a good start. We're just gonna look at that. So I have no clinical, no relevant disclosures pertinent to this talk, but I gotta remind everybody that in terms of regulatory status, the FDA considers both PRP and BMAC to be investigational, so we'll get into that further in a little bit. So we're going to go over the basic science for PRP, go over some of the regulatory aspects, discuss what's in PRP and BMAC, and then how to dose them correctly, big topic nowadays, and then go over some of the differences between the two. So we use PRP, because peripheral blood is easy to access, plentiful, and it contains 3 elements that are critical in tissue healing, right? So you get your platelets, of course, and we got white blood cells and then plasma proteins. And these are all gonna be essential in the healing process. So there are at least a dozen or more clinically relevant growth factors and cytokines present in the platelets in our PRP that come into play with regard to cell proliferation, extracellular matrix synthesis, and regulation of inflammation. And white blood cells in our PRP also play an important role, and depending on which tissue we're talking about, say tendons, extensor carpi radialis brevis, other things like the meniscus, where you might want to have different types of white blood cells in there, they may play a critical role in whether or not someone heals. And of course, there's plasma itself, either in its native form or its concentrated form, which is valuable when we're treating atrophied or injured muscles. So we used to think about BMAC as being a source, for muscle, bone, tendon, ligament, and cartilage progenitor cells, but we don't really think about it that way anymore. So BMAC is full of platelets, like PRP, but it also contains what we now call medicinal signaling cells, originally referred to as mesenchymal stem cells, now referred to as medicinal signaling cells, or MSCs. It also contains HSCs and EPCs. We also call MSCs pericytes because that's where they live. They live on the blood vessel walls within our bone marrow. And bone marrow plasma is also full of interleukin-1 receptor antagonist protein and alpha-2 macroglobulin at levels which are much higher than we find in peripheral blood. And we'll get into that a little bit more. So thankfully, we've got a group here who already knows that PRP is efficacious across a wide variety of musculoskeletal disorders. And we don't need to convince these people that it works because we see them every day in our practices. But does the literature support this? Indeed, it does, with countless, at this point in time, really, it's more every day. Level 1 and 2 studies showing efficacy and most times superiority of PRP over standard of care therapies such as steroid and HA when we are delivering properly dosed PRP. So no discussion about PRP and BMAC would be complete without talking about the regulatory aspects. So when patients come into your office, you start talking about PRP, first question they're going to ask is what? It's covered by my insurance, right? So the answer for that is no. Second question is sometimes, well, I've heard it's not FDA approved, and that's also true, it's not. And this is where it gets a little tricky. So blood, peripheral blood, is not considered to be a human cellular tissue or product, and therefore is not regulated by the FDA. But PRP kits do require 510(k) clearance from the FDA in order to be used, and those are then only cleared for use in a specific setting. That's when it's in the OR, when the PRP that you're making is going to be combined with bone graft in the OR for use in the OR. So any use outside of that very narrow window is considered off-label. So that would be in your office. So you're using an off-label device to create a product that's not technically regulated. Bone marrow aspirate and bone marrow concentrate is considered to be a human cellular tissue and product and is therefore regulated by the FDA. But in a very specific set of circumstances, it is considered exempt from the rules that say you can't do that. And that is when the product is being used in an autologous manner, meaning like it's coming out from you and going back into you. It's homologous use, so that means the bone marrow is serving the same role where you're putting it as the place where you took it out from. It has been minimally manipulated, so you can't take it out and put it in your lab and chop it up and then culture expand it or do whatever you want. You can't do that. It must not have a systemic effect, so the effect must be local, and you can't adulterate it, can't add anything to it. And probably the most critical thing is that the cells have to be taken out from and put back into the same individual during the same surgical setting. Follow those rules and you're okay. So here are the terms and products that are currently off the table. Not to say that I don't think there's some value in these things. It's just right now the regulatory status of these things is pretty clear. It's crystal clear. You should not have the word stem cells on your website. If they are, there will be an FDA bot that crawls around and finds it, and you will get a letter from the FDA, and you don't want a letter from the FDA. And no matter what you see on LinkedIn or an email from somebody or here at the meeting, there are no currently available stromal vascular fraction products, amniotic tissue products, wart and jelly products, exosomes, or anything sort of like that available in the US. None. All of them are illegal. So don't use them. So how do we decide what kind of a kit we want to use when making PRP? There are 4 basic elements. It should have that 510K clearance. It should be of sufficient blood draw volume to make a decently potent PRP. Weak PRPs are terrible. They don't work. It should allow you some flexibility, so you should be able to do a single spin or a double spin, and you should be able to make a leukocyte-rich PRP, red PRP, or a leukocyte-poor PRP, so an amber PRP. And it should have a high platelet capture rate. So if I treat a knee where the person has arthritis, but they also have a meniscal tear, I want to put leukocyte-rich PRP into the meniscal tear, just a small volume, 1 or 2 cc's. But if they also have arthritis, I want to put a larger volume of platelets into the knee joint itself. So I need to have something that does both. This does both. So a small concentrated volume leukocyte-rich PRP, like 8 cc's of a leukocyte-poor PRP. And as long as your blood draw volume is high enough, you can do that with a single blood draw volume. So you have to have something that's flexible. Platelet recovery just means that you're not going to capture every platelet from your peripheral blood draw in your PRP. Some of them will escape capture. So it's surprising, but if you read the fine print, the recovery rate can be 29% or 90%. So you got to read the fine print. So when we are making PRP, we do not want to use kits that we draw out 8 to 10 cc of blood. Okay, simple math says the more blood you draw, the more platelets you have. If you use a weak PRP in almost every musculoskeletal disorder, maybe not dermatology, maybe it doesn't matter as much in that realm, but if you use a weak PRP, you will fail. Bonsal's 2021 paper kind of was one of the first ones. There are a couple out there now that show as long as you get 10 billion platelets in an 8 cc volume, you will have good outcomes going out to a year, and that's in a NEOA model. But there are others coming out daily, it seems. So when we are making PRP, we have control over a number of different things. We can control the speed of centrifugation. We can control the centrifugal force with speed, but also with the arm length in our centrifuge. We can also control the time of centrifugation, and then the volume of our devices, as well as the volume of blood that we put into our devices. So by controlling all these things, we can either create or not create a buffy coat, and that allows us to get into a leukocyte-rich or leukocyte-poor preparation. So on the left, we have decided to make a leukocyte-rich PRP. So we're going to treat something that requires that. So like a common extensor tendon, meniscus, something where we know leukocyte-rich is going to do better. So we've had our first spin. We have created a buffy coat, and then the PPP layer, the platelet plasma layer up here, is like clear. We got red cells down here. This is going to be clear yellow, like a Bud Light that's been sitting out in the bar all night. So we put the buffy coat in a second container with that PPP. We spin it down, and we're going to have a platelet plug at the bottom of that container, which is red in color. When we resuspend that plug in whatever volume of plasma that we want, we're going to create a leukocyte-rich PRP, and this will be red in color, like we saw before. Over here on the right, we have a different preparation. We're making leukocyte-poor PRP, so we've taken a different spin parameter. We have the RBCs, but there is no buffy coat, so we've just got this stuff up top, which is hazy. Looks like a New England IPA. It's called platelet plasma suspension, or PPS. So we take all of that PPS, stay away from the RBC layer, put that in a second container, spin that down at the bottom. There'll be a platelet plug, which will be yellow, white, maybe slightly red tinged. Don't worry about that. You resuspend that in whatever volume of plasma you want. You're going to have leukocyte-poor PRP, which is a bad name because it contains a ton of monocytes and macrophages, but it does have a relatively low concentration of neutrophils. So it's less inflammatory, but it does have white blood cells in it, which are critical in the healing process. That handsome young man, Matt Murphy, in the back somewhere, has an excellent video online, and I've heard him lecture multiple times on the concept of single spin versus double spin, buffy coat versus non-buffy coat. Can't read that. 5 minutes? Oh, I'll be done long before that. All right, so look at his video online. You know, the amount of volume of plasma that you take off of that platelet plug will determine what volume of PRP you get at the end. So when we make PRP, we of course add ACDA to keep the blood from clotting. If we want to activate our PRP, we can add calcium chloride, and if we want to make a PRP clot, we can add recombinant thrombin to make that happen. Or we can take a kit, manufacturing kit down at the bottom, and collect non-citrated blood, or we can just put non-citrated blood in red top tubes, let those clot over 15 minutes, centrifuge those, and collect the supernatant, which has autologous thrombin in it. Arnold Kaplan, the godfather of stem cells, passed away earlier this year, and that's the only time I'm going to say the word stem cells, because he asked us to stop calling them stem cells and call them mesenchymal stem cells to begin with, then medicinal signaling cells, because that's how they act. They're not really precursors turning into muscle, bone, ligament, and tendon. They're acting as orchestrators, conductors of the cell-to-cell communication that then results in cell healing over time. So in his honor, let's stop calling them stem cells. So in bone marrow concentrate manufacturing, collection technique is critical. We have two different techniques here. One is a multi-site technique. The other one is a multi-direction technique. Each of them are trying to maximize the MSC yield and minimize the collection of peripheral blood. The highest concentration of MSCs is found directly below the cortex, so we do not need to drive that needle deep down into the marrow space to collect high levels of MSCs. However, multiple subcortical sticks may be required in order to achieve that. So this video shows two key things. Number one, they're using a 10 cc syringe. So throw away your 60 cc syringes. You do not get enough suction to collect MSCs preferentially over peripheral blood. Number two, that technique that they're doing, it's a snapback technique or a rapid pull technique. Philippe Hernigou has proven that these two simple alterations to our technique have great and positive impacts on the percentage of MSCs that we collect in our marrow collection. The choice of anticoagulant that we use during marrow collection may matter. Ryan Dragala showed that he had better CFU counts and cytokine levels in cultures prepared from BMAC made with heparin compared to BMAC made with ACDA. So use heparin. Don Buford's simple calculations show that if we have 18 million total nucleated cells, which is a non-linear surrogate for MSCs per cc of bone marrow, and we believe that those cells have therapeutic benefit, it would make sense that we want to concentrate them before injecting them back into the body. And we achieve this through centrifugation. Simple. Very much same principles as PRP. Centrifugation also allows us to take a 60 cc blood draw and make it whatever concentrate we want, which is appropriate for our procedure. So when we're making BMAC, we definitely want to be using a technique that creates a buffy coat. We take all that buffy coat and a tiny bit of the RBC layer to make sure we're getting all of the MSCs possible. We also do not throw away this red-tinged PPP over the buffy coat because it's got a lot of IRAP and A2M in it, which can be concentrated with those filters. So in terms of the literature, it's pretty much parallels the PRP literature with kind of anecdotally, I think, across the field, we feel that BMAC gives you a longer duration of effect compared to PRP, and the literature seems to bear this out. So if you're not doing PRP and BMAC, there's really no reason not to start. Get a 510K kit, get some good communication with your manufacturer or a rep, and you can start. Is it nice to have cell counters so you can see your platelet levels before and after? Sure. Is it standard of care? No. Is it nice to have a registry and you can show patients your own data from your own patients and show them what they should expect in your clinic? Absolutely. That's what we do. Is it standard of care? No. Should it be a barrier to you starting? No. So in summary, oops, stop that, blank back. How'd that go? So summary here, we have procedures and products that are FDA compliant and they are safe. They allow us to provide drug-free solutions to musculoskeletal pain issues for our patients who either can't have or don't want steroids. They have much shorter recovery periods compared with surgery, and most importantly, they are non-surgical. So finally, if you are not offering these patients to your these products to your patients, they will go elsewhere and they'll get them from somebody else who we all know may be doing a substandard job because they don't know some of the things that you now know. So thank you very much for your attention. You can always find me chirping about something on LinkedIn. Reach out to me there. A billion references that actually are pertinent to the talk. And please email me or call me, and happy to answer any questions. Thank you.